Shall I go? Am I audible now? think I think it's got a poor. I'll just check again. Am I audible now? Vinod, am I audible now? Fine, fine, okay. Okay. Good evening, friends. I'm Dr. Venkatesh, a consultant urologist and faculty from team RRM Next and DocTutorials. So we are happy that this NEET SS 2025 had finally happened, and I think the paper was pretty much standard. So we are going with the recall sessions. So this time I'm going to focus this recall session only confining to those topics on urology and basics of transplant. So there were some 13 odd questions which has been covered from the out of 150 questions that has been asked. Okay, it's a decent proposition. And in general, whatever my assessment based on this urology question from urology and transplant is, they're very simple and straightforward, and most of them are concept based questions. There are, maybe I could say, pinpoint one or two questions which are slightly vague. Okay, and at the outset I would like to thank all our students, because of their if not for their efforts of to recall the questions, very difficult for us to get all those 150 questions and do a recall. Of course, there will be few ambiguous question stems or options because it is completely based on memory recall. So sometimes it may not be a replica of exact question that was asked in your session, but as always, we try to gather information from most of our students. We sit down and do the work, and we assimilate what could be the possible most possible questions and options to them, and we have come out with this recall. Okay. So at the outset, again, I would like to thank all our friends and students who have helped us in collecting all this recall session. Okay. So as we see here, most of the I have given this entire recall session is based predominantly from the references from Bailey and Love, that is the latest 20th edition, as well as the latest 22nd edition of Sabiston. And I also added one or two references from Camel if needed for some selective difficult questions. Okay, right. So we'll go with the first question. Which of the following immunosuppressive medication causes coronary vascular thickening? Okay. So if you ask me in this whole spool of question, I would say this is one of the most difficult questions because there were some references which I could get from Sabiston and Sabiston, because Bailey didn't touch much about this immunosuppressive drug as well. So, but I also went back and referred certain articles. This is from Campbell, and I will try to give you the answers. Okay. So the questions are, the options are A, calcineurin inhibitors, B, corticosteroids, 3 is mTOR inhibitors, and the azathioprine. Okay, this is basically a question based from the side effects of that is the adverse effects of all the common immunosuppressive agents which we have discussed, which I think I thoroughly have discussed when I talked about the basics of immunology and immunosuppression in the transplant session as well. Okay, so all those who have read through and watched our video lectures from DocTutorials, I think you'll be able to answer this. Okay, so the answer here is it's a calcineurin inhibitor. Okay, see, most of this drugs, some other drugs, even corticosteroids, also has an atherosclerotic potential which can cause coronary vascular wall thickening. But why I say calcineurin inhibitor is a better option is because of this reference. So this reference was taken from Sabiston 22nd edition. As you see here, there's a one unique feature with this calcineurin inhibitors. Okay, calcineurin inhibitors like cyclosporin. What happens is they have a as you go through this, this action is mostly mediated through increased levels of transforming growth factor beta levels. Okay, this is the culprit. Okay, what is going to happen? This increased TGF levels is going to cause endothelitis. It is going to increase the level of endothelin, which is a potential vasoconstrictor. Okay, this calcineurin inhibitors. Okay, calcineurin inhibitor is likely to increase the transforming growth factor beta levels. Okay, so this in turn is going to increase the endothelin levels, which is going to cause a vasoconstriction effect, and it's also going to cause endothelitis and fibrosis. Okay, which in turn can result in coronary thickening. Coronary thickening. Okay, so this comes to very close to the exact question which was asked. Okay, this causes results in remodeling. It's a condition called remodeling, which can induce the fibrin deposition and can result in fibrosis. Okay, which can predispose to subsequent atherosclerosis. Okay, right. So when I went back and gone through other articles, I could get these references. Okay, as you see here, cyclosporin. Okay, the cyclosporin is associated with endothelial dysfunction, and it is because of proliferation of smooth muscles and endothelitis. All this is because of transforming growth factor levels. It's all because of increased transforming growth factor beta levels. Understood? Okay, so and which is going to cause increase the vascular inflammation and coronary vasculopathy. So the answer here is calcineurin inhibitors. Understood? Right. So this is the three count. This is one article which I have referred. So this shows. So this shows the effects of this. This was a study which based upon the cardiac effects of the commonly used immunosuppressive agents. As you see here, this calcineurin inhibitors is most likely to have vascular remodeling, that is vascular thickening, and increased risk of coronary artery disease is more likely to happen in these group of immunosuppressive drugs. Understood? Right. So next is a very simple, straightforward question. I think most of you would have answered correct. And I would tell All these questions have been taken from you. If you have gone through my lectures from the for the urology in the NEET SS section itself, I think I have covered almost all the topics. All these questions could have been directly, easily been answered by just by watching our lectures only. Understood? Of course, all these lectures are predominantly based from our Bailey and Sabiston. So what we mean to say is we have completely extensively covered all those things in our video lectures. And if you have read and watched the lectures and if you have revised the contents properly, I think you should have got all the 13 out of 13 questions from urology and transplant. Okay. Next is a patient presents with a 3.5 centimeter solid renal mass, which is asymptomatic and it is confined to renal capsule. What is the most appropriate treatment? So here it is a case of a incidentally picked up renal mass. Okay, it is about 3.5 centimeter in length and it is completely asymptomatic. So what are we going to do? So the options are A, partial nephrectomy, B, radical nephrectomy, C, observation, and D is chemotherapy. Okay, so remember, as I already said, renal tumors, any enhancing mass lesion in renal kidney has to be considered as your renal cell carcinoma unless proved otherwise. So it is a malignancy and it has to be removed. And remember, all the RCCs are intrinsically chemo and radio resistant. Okay, so the chemotherapy, radiotherapy is not going to helpful. And remember, unless in very selected cases, there is no role for observation in a solid renal mass. Now we have two options, whether to go for a complete nephrectomy or you have to go for a partial nephrectomy. Okay, so remember, this is a kidney, okay, and you have got a renal mass, okay, endophytic or exophytic. It is about 3.5 centimeter in length. Okay, so now the treatment option is so if you go through the staging, it is a T1 stage. Okay, what is T1? T1 means any lesion that is less than 4 centimeter has to be considered. So for any T1 disease, okay, T1 RCC, unless there any contraindication, the treatment option is to go for a nephron sparing surgery. So the treatment option is nephron sparing surgery. So mostly it is in the case of a partial nephrectomy. So there is no doubt about it. So the correct answer here is partial nephrectomy. Understood? So these are your references. Okay. This was directly from Bailey and Lowe. We see here partial nephrectomy should be the treatment of choice in tumors less than 4 centimeters. Okay, and in well selected, even in tumors between 4 to 5 centimeter or bilateral tumors or solitary tumors, still you have to offer a nephron sparing surgery in those conditions. Understood? Right. So next is, we'll come to the next question. Okay, this is quite an interesting question. A 1-year-old child with right side undescended testis is present to you in your OPD. Okay, the testis is not palpable in the inguinal region. A diagnostic laparoscopy shows viable intra-abdominal testis. What is the most appropriate management? Okay, so here the options are little dicey. I don't really know whether there is any mistake in the recall, but whatever that information we have collected through our students, I have pulled in 4 different options. So you see here, you see a case of an undescended testis in an 1-year-old child. Now the option is, what is the ideal time to treat an undescended testis? Okay, you have to wait only till 6 months. Okay, any child with undescended testis more than 6 months, it has to be operated. The ideal time, as Bailey says, is somewhere between 6 to 18 months. Okay, that is a point. So there is no doubt this child has to be operated. Okay, and do we have to do an orchidectomy? Of course, obviously we should not do an orchidectomy in an young child, especially less than 1-year-old child. You should never do an orchidectomy, because our motive is to preserve as much as testis as possible. Understood? So orchidectomy is never an option. So what is Fowler-Stephen? So the options are whether to do an Fowler-Stephen upfront procedure, that is, we are going to do a laparoscopy. Diagnostic laparoscopy already been done. You have seen an intraabdominal testis, and we are going to bring the testis to the scrotum, and we are going to place the daughter's pouch. So that is the treatment. So we know the treatment. Okay. So now here the question, here the doubt happens to us. Okay, so now whether to options are two-stage Fowler-Stephen procedure with 3-month gap, two-stage Fowler-Stephen procedure with 1 year gap, and single-stage Fowler-Stephen procedure. Okay, so previously what the idea was, because the testes are very small and it has got very small testicular arteries and vast differences, sometimes you cannot completely mobilize. So this is an olden school of thought. Okay, olden school of thought, you could not mobilize. So what happens is you need to have a sufficient length of the testicular vessels. Testicular vessels. You need a blood supply to the vessel. Sometimes the simple testicular artery will be very short. It will prevent the normal positioning of testis inside the scrotum. So in that case, what we will do? In this case, Fowler Stephen defined the procedure. So what he did was he just initially clipped the testicular artery without disturbing the testis from its bed, surrounding structures. The idea was once the gonadal artery, the testicular artery is being cut, okay, just clipped. Okay, we don't cut it in a Fowler Stephen stage. We are going to clip it, and so that we will wait for the collaterals to develop. So how long to wait? The usual waiting time in Fowler Stephen procedure is the first stage is to clip the testicular artery. Okay, clip the testicular artery. And the stage two, whatever you wait for the collaterals to develop. Okay, how long to wait? Usual waiting time is 6 months. Okay, you should not go early. The idea is wait till 6 months for the collaterals to develop to testis. Okay. Once a sufficiently testis vascularized by collaterals, you go for the scrotal repositioning. Okay, you have to bring it to the scrotal repositioning. Okay, so the treatment, so the option was 6 months. Okay, but here we are given with in a dicey situation. One is 3 months gap. So obviously 3 months gap should not be, it's not sufficient because it is not going to be helpful. Okay, and 1 year is quite a too long a gap. And single stage Fowler Stephen procedure. Remember, it is always not mandatory to go for a two-stage procedure. When you feel, as an operating surgeon, you feel the testis can be brought down to scrotum in single stage. That is our first motive. So idea is to do the surgery and bring the testis as early as possible to the to its normal anatomical scrotal position. Okay, only in very rare cases you feel it is difficult, you go for a staged procedure. Okay, so now with the advancements of laparoscopy, it is very feasible to even go till the kidney where you see the origin of the testicular arteries. You can release the arteries along with its attachments, and we can bring the testis to its normal position even in a single stage in most of the cases. Okay, so and one dicey situation is there's no clear cut defined criteria as which of those patients who needs a single stage and double stage procedure. Okay, so by all these purposes, I feel the right answer is to go for a single stage Fowler Stephen procedure. Understood? So for that, I could get a decent reference. Okay, so as you see here, this was from the Sabiston, latest Sabiston 22nd edition, page number 1971. You see here. So, for an intra-abdominal testage, two-stage Fowler Stephen procedure was considered. Okay, is considered. Orchidopexy is considered, and the testicular vessels are ligated, and you can wait for about 6 months before orchidopexy is being performed as a second stage procedure. But look at this new statement. Okay, laparoscopic orchidopexy has been popularized as an ideal single stage option, which allows the full mobilization of testicular vessels to the level of the base of the kidney. So that means with advancement of laparoscopy, we have a better vision and magnification. Most of the cases we can get away with a single stage mobilization. So that was the answer to this question. Got the point? Okay. Now we'll go to the next question. Okay. So as I even Bailey also touches the same thing. Okay. So laparoscopic one stage follows if the vessels are divided and dissected off the pedicle and broadened in one stage. Okay. Right. And if you plan for a two-stage procedure, the optimum time is at least 6 months, not 3 months as given in one of the options. Understood? Right. Now, this is one important one, another interesting question. So, I think it was an arbitrary image we have taken from some various resources. The picture may not be exactly the same, but mostly this was a question which most of students have recalled. A voiding cystourethrogram image of a boy showing a dilated bladder and keyhole sign is given. Okay, so probably it's a voiding VCUG. You see a distended bladder. Okay, you see a distended bladder, and there is a proximally dilated urethra. And there is one more ultrasound image which shows a keyhole sign. Keyhole sign means there is a dilated bladder, and one more thing is your a dilated urethra, which will remember like a keyhole. So, what is the probable diagnosis? I think it's a very simple, straightforward question. I believe most of you, all of you should have got this question right. So the answer here is very simple. It is your posterior urethral valve. Why posterior urethral valve? Because of a valve which is pressed extending from the bladder neck just till the to the level of the membranous urethra, bulbomembranous junction. So because of this obstruction, there is going to be dilatation of the posterior urethra as well as the dilatation of your bladder. Okay, dilatation of your bladder. So it's typically seen in posterior urethral valves. Okay, so what is the reference? This was taken from directly picked from Bailey and Lowe. This is an exact image which was taken from Bailey. As you see here, you see the bladder is dilated and this posterior urethra is also significantly dilated. Understood? So, what is the treatment option? So, what is the investigation? The investigation shows a voiding cystourethrogram. Investigation shows a voiding cystourethrogram, which shows a dilated posterior prostatic urethra. Okay, right. Next, we'll go to one more question, which is again a simple, straightforward pick from your Bailey and Love. Okay. So this also I have taught in the video lecture as well. Understood? So a raspberry sized mass, which is of size of a P is noted in the noted per urethra in a female patient who presents with difficulty in micturition. So what is the next step? Understood. So what are you looking at? You are looking like a small P-shaped mass which is like protruding through the urethra in a female, in a old female. So what are the next steps? So probably this diagnosis is usually an urethral caruncle. Urethral caruncle. Okay. So what is urethral caruncle? Nothing but a prolapse of the urethral mucosa. What is the treatment option? Remember, it is mostly it may present with bleeding on touch. Okay. So most option is excision and coagulation of the base using a cautery diathermy. Okay. So that is the treatment, is the option here. Okay. So just we'll go back and see the references. Okay. This was a picture which I had taken. As you see here, from the urethral opening, you see a small protrusion from the along at the side of the urethral opening. Okay, so it presents a soft raspberry mass about the size of the pea, and it is treated with excision and diathermy coagulation of the base of the stalk. Right. Next, we'll come to one more question. Okay. So this time there were 2 to 3 questions from urological trauma as well. So I have discussed everything in detail in our lectures. Okay. So you had couple of questions from the urological trauma. One was from renal trauma, one was from ureteric injury, and 2 questions are from urethral injury. So again, as I said, this trauma is a very, very important high yield areas. That's why I have discussed them much in detail in our video lectures as well. Okay. Understood. Now we'll go to this next question. A patient after a road traffic accident shows right renal hilar injury on contrast and CT and the patient is unstable. So which incision would you prefer? So previously there were a lot of questions you've been asking about the grading of renal trauma. This time they've gone a bit advanced and now they have asked about what are the approach to explore a patient with unstable renal trauma. Okay, so the options are you go for a midline laparotomy, you go for a flank incision, a right subcausal incision, and a clamshell incision. Understood? Now it is very simple. Remember, it is an RTA with blunt trauma, and the patient is very much unstable. You're not just focusing only on kidney injuries as well. You may likely to have other bowel injuries or other intra-abdominal organ injuries as well. And remember, whenever you suspect a renal trauma, the approach is always to go for a trans-abdominal approach. So remember, trans-abdominal approach is our way. Okay, because why? Two things. Okay, trans-abdominal approach is the faster way to open, and it gives access to the entire peritoneum and retroperitoneum. Okay, peritoneum as well as your retroperitoneum. Okay, and remember the vascular control even in patients with renal trauma is easier. Okay, it is easier because you are going to expose the major vessels and it's easier to have an early control. That is very, very important. So the answer here is midline incision, midline vertical incision. Okay, there is no doubt about it. Remember this question, you get a reference from your Sabiston. Okay, Sabiston 22nd edition, page number 389. Okay, remember So I think these things I've already discussed anyways, just for the sake of I think the absolute indication for interventions are expanding and pulsatility to peritoneal hematoma, hemodynamic instability, and the patient is not responding, and suspected renal pedicle vascular avulsion and UPJ avulsion. Okay, these are the absolute indications. Okay, so as you see here, what do you see here? Remember, renal exploration should be performed through a trans-abdominal approach. Trans-abdominal approach, which allows complete inspection of the viscera. Okay, remember, and through this, it is easier to. And how are you going to approach this case? Remember, the small bowel is lifted out of the abdomen, and the incision is made inferior to the inferior mesenteric vein. Okay, so by this you are going to go to the direct inter-aortocaval groove and you can able to visualize. Remember, whenever you open up for a trauma, the kidney region is already filled with blood. Okay, filled with blood. So once you open up, the tamponade is even going to be lost. So it is not easy to identify the hilums. It is better to go to the major vessels, identify the inter-aortocaval groove. You can go to the renal origin of the renal arteries, and it is easier to take a control. So that is why it is always preferred to go for a trans-abdominal approach. Okay. Now one more question. This was again from posterior urethral valve. Okay. So an image of posterior urethral valve with restrained bladder was given. What are the initial step in the management? Understood. So the options are A. Endoscopic valve ablation, B. Suprapubic cystostomy, C. Regular follow-up with imaging, and passing an infant feeding tube to drain the bladder. Okay. Remember, this is a case of posterior urethral valve. How does a child present? The child presents with difficulty in pass urine. Even after the birth, the child is not able to pass urine. You see the patient is having incessant cry, the lower abdomen is distended, the bladder is palpable. Okay. And sometimes the patient may even present with features of uremia. Okay. Why? Because these childs present with a typical of bladder outlet obstruction. So what are we going to do? See, of course, all these options are can be done, but the question is very simple. What is the initial step? What is the initial step? The first step is to drain the bladder. Once you drain the bladder, the child is going to improve. The hydronephrosis is going to settle down, and it is going to happen. Remember, in posterior urethral valve, the problem is in the in the antegrade passing of urine. Remember, there is a valve which is causing obstruction from the bladder neck all the way till the verumontanum and extends till the membranous junction till the level of sphincter. So this antegrade flow is blocked, but remember it is like a flap valve. You will be able to pass a catheter, retrograde catheter, all the way retrograde into the bladder. So catheterization is always possible. Okay, so the ideal treatment is passing a infant feeding tube to drain the blood. That is the first initial step. You stabilize the child. Once the child is fit enough, the child has got is recovered from uremia, then you can take the child for endoscopic fulguration. Many times suprapubic cystostomy is not needed unless there is very conditions. In that condition, what we'll do is we will do a we'll do a we don't do a routine trocar cystostomy. We will take the bladder and suture it to the anterior abdominal wall per se. Okay, right. But remember that is in very select cases where the child is very sick and not fit for endoscopic fulguration. Now with the advancement of miniaturization of scopes and even lasers and bug-bay electrodes, most of the times if the child is fit enough, we can take the child for endoscopic fulguration. Understood? Right. So you see here, this is again a direct pickup from Bailey and Love. The page number is 1539. See, the initial treatment is by catheterization. Initial treatment is by catheterization, drain the urine and decompress the bladder. And the definitive treatment is, again, as it's an endoscopic ablation of valves, endoscopic ablation of valves. And remember, a PUV child is more likely to develop end-stage renal disease in the future, and this child has to be followed up for sure in the future as well. Understood? Right. Next, we'll come to one more question. As I said, there is so much of focus on trauma. So here is also one more question which is happening here. Okay. So a patient with a renal road traffic accident with pelvic trauma, the patient has got blooded meatus. Which investigation is best to confirm urethral injury? Okay. So you see here, the patient has got pelvic trauma. There is a pelvic fracture. Okay. And this is because of the pelvic fracture, most of the times I already told, I have taught you in the classes, okay, this is the bladder, this is the prostate. Okay. So here you have your prostate. Remember, this is going to be in the pubic bone, behind the pubic bone. There is one strong ligament which is going to attach the prostate and the prostatic urethra. What is it called? It is called pubourethral ligament. So what happens whenever there is a shear force of pelvic fracture, there is going to be one fixed part and one loose part. So remember this posterior urethral ligaments, okay, PULs are going to strongly fix the prostatic urethra. So what happened? There is going to be a shear force and there is going to be a disruption. Okay, this is called pelvic fracture urethral distraction defects, okay, or pelvic fracture associated urethral injuries, okay. So this is the term. So what happened? Most of the time there is going to be disruption at the membranous, at the bulbo-membranous junction, okay. So this results in urethral injury. Because of the urethral injury, what is that the patient going to present? They're going to present with some blood at the meatus, and the patient is always going to present with distended bladder. So when you suspect this, what is the initial treatment of choice? The initial treatment of choice is always retrograde urethrogram. What are you going to do in retrograde urethrogram? You're going to fill the urethra with the contrast, and you're going to see what do you see in a retrograde urethrogram. You're going to see contrast extravasation. So that is the confirmatory test whenever you suspect an urethral injury in a patient with pelvic trauma. Understood? So this is directly I have discussed multiple times in our lectures as well. So and is also you see direct reference from your Bayesian law. Okay, remember. So the investigation includes retrograde urethrogram. Investigation includes retrograde urethrogram. Okay, right. Next is one more question. Again, this is on trauma as well. Okay, a stable patient. This time, a stable patient is undergoing elective laparoscopic sigmoid colectomy. Okay, and he had a left side ureteric injury about 3 centimeters from VUJ. What is the appropriate management? Okay, so remember, this is a left-sided ureteric injury. Okay, this is your kidneys, and from the kidneys, you are going to have your ureters. And the ureter is going to drain into your bladder. Okay, so what do you have? What do you see? You see an ureteric injury about 3 centimeters. It's not so far, it's about 3 centimeters from the vesico-ureteric junction. So what happens? Remember, for any distal ureteric injuries, the distal vascularity is going to be difficult, and it is easier to anastomose the ureter to the bladder per se. So the treatment option is go for a ureteric reimplantation. That means you are going to disconnect the segment and you are going to do a direct anastomosis to the bladder. So advantage is you are doing a more vascular anastomosis. The bladder blood supply will help in healing the neo anastomosis. Okay. So remember, end-to-end anastomosis is very difficult in the distal ureters, which we don't do that. And ideal continence is too much. We don't do it for ideal continence whenever you do when the ureter is significantly for a long segment it is damaged. Okay. And transureterostomy usually it was done in olden days where you mobilize one end of the urethra. Okay, you mobilize one end of the urethra and anastomose to the contralateral. Okay, for example, if it is here, this is called transureterostomy. Transureterostomy is not done these days. In very rare circumstances, we tend to do that because the retrograde approach, the anastomosis is all going to be very narrow, and vascularity is also significantly going to compromise. So the treatment option here is go for a direct ureteric reimplantation. Okay, right. So where do you get the reference? So remember this renal trauma, the trauma chapter has been very beautifully described in Sabistan. The latest edition has actually included a special chapter on urological trauma, okay, in the basic initial chapters as well. So I'm going to touch them. I'm covering them in the latest update new lectures which are going to cover as well. Okay, you see here, remember the injuries distal to iliac vessels can be reimplanted into the bladder. Okay, reimplanted into the bladder. That's the best treatment option available. Okay, right. Next is again. So this is again a question based on trauma. Remember, patient with road traffic accident present after several months with RGU image showing a long segment stricture at bulbar urethra. What is the most appropriate treatment step in the management? So options are end-to-end anastomosis, buccal graft augmentation uretroplasty, video video endoscopic internal urethrotomy VAU, or none of the above. So what are the best options you have here? So remember, it could be a it could be a buccal graft. So remember, so this is the case. This is the case of a. So I'm not sure about this question, but it shows that the long segment narrowing at the bulbar urethra. Okay. So whenever you come across a long segment, or you come across a long segment bulbar urethral strictures, okay, long segment stricture. You cannot go and do an end-to-end anastomosis. But remember, there is slight discrepancy, which I'm not sure whether the recall is perfectly right. Remember, if it is directly because of trauma, it is going to be fibrosis. There is not going to be much of inflammation, but it is going to be a short segment but dense fibrosis following a trauma. So in that case, any traumatic strictures, it is going to be short, and you can go for offer an end-to-end erythroplasty, anastomotic erythroplasty, wherein you're going to excise the short segment, going to suture it, spatulate and suture the opposite urethral lens accordingly. Okay, that is one option. But this long segment strictures following traumatic strictures, traumatic injuries are very, very rare. Okay, that's why I'm little doubtful about the proper recall of this question. Okay, but whenever you see a long segment structure, this end-to-end erythroplaty is going to be very difficult, and it is almost impossible. How are you going to bridge a defect about 5 to 6 centimeters? Very, very difficult. You can't do it that way. So in that case, the treatment option is you have to go for a augmentation erythroplasty. What are you going to do in augmentation erythroplasty? Remember, this is the urethral lumen. Okay, so it has become narrowed and fibrous. So what you're going to do, you're going to cut open the urethra here. You're going to open the urethral plate, and you're going to put a wide graft on all the side, across the side. So preferably you're going to take a buccal graft, okay, and you're going to suture with this, okay. This is called buccal graft urethroplasty. Okay. The one, if not for RTA, then that option is perfect for any long segments. You go for buccal graft mucosal urethroplasty. But given this condition, I still going to stick on to this as the right answer. Buccal graft, buccal mucosal graft, anastomotic erythroplasty, augmentation erythroplasty. Okay. So remember again the reference, you take it from Bailey. As you see here, augmentation erythroplasty is performed for non-traumatic and long segment strictures. Okay, in this type, a structure segment of urethra is incised and augmented with a patch, usually a buccal mucosal graft. Okay, right. Next is, I think this is the last question we have here. So remember, this is a patient. A patient is diagnosed with a non-seminomatous germ cell tumor. What is the first line chemotherapy? So I have discussed this multiple times. Remember, it's a non-seminomatous germ cell tumor. And what is the chemotherapy? The chemotherapy for any testicular tumor is BEP, that is bleomycin, etoposide, and cisplatin. Okay, BEP based chemotherapy. Okay, so you do chemotherapy 2 to 3 cycles, then you're going to reassess by repeating a staging, and then if the tumor markers are come down, the nodes is upside, the treatment is done. The tumor markers, then you divide them into progressive disease and stay responding and non completely resolved. Okay, if it is a progressive disease, then you have to go for a second line chemotherapy. If the patient is, there is partial response, and you see if there is a residual node, then you go for a post chemotherapy RPLND, post chemotherapy surgery. Or even if it is not responding, then you have to go for second line chemotherapy. Understood? So the option is very simple. It is bleomycin, etoposide, and cisplatin based chemotherapy. Right? So again, the references from Bailey and Love from 28th edition. Okay, right. So the initial treatment is chemotherapy, BEP in all advanced ages. Okay, all advanced tumors. Okay, right. So thank you. I think I have covered all the recall questions. All the recall questions that included both Bailey and both urology as well as the immunology section. Okay, understood. So I think we will conclude this discussion here. So I hope all of you have done well. We sincerely pray that all of you have are going to come out with good ranks, and I wish you all the very best for your future as well. Thank you. సరే. ఓకే పా.